All right, let's do it.
All right.
All righty, starting her up.
Good morning, friends. This is George Fichette here in Chicago with Transforming Chaplaincy. Welcome to the third Strategic Thinking webinar series of the 2018 year. Our topic today is challenges in healthcare delivery and their implications for spiritual care. I want to introduce you to today's participants, serving as host today is Gila Rajai. Gila is one of the Transforming Chaplaincy Fellows. We're very delighted that Gila has been with us in the Transforming Chaplaincy Project. She has recently completed 2 master's degrees at the University of Michigan School of Public Health and the Gerald R. Ford School of Public Policy. One was a master's in public health and the other was a master's of public administration. Gila is actually staying at the University of Michigan. I don't know what that's about. Why would you want to stay at the University of Michigan? But anyway, she's staying at the University of Michigan, and she's going to be doing a PhD in the School of Public Health in health behavior and health education. And we're really just delighted about that. Gila holds an MDiv from Princeton Seminary. She's a board-certified chaplain with the Association of Professional Chaplains, been a chaplain for about a decade. Some of you will know Gila. Actually, she's served in leadership in APC and particularly has served in leadership in the APC annual conference planning for a number of years. Gila's research interests include an interest in population health and the impact of chaplaincy interventions on health outcomes. We're really glad to have Gila help guide this conversation because of the Transforming Chaplaincy fellows and faculty. You know, people like me are just kind of getting into the details of study design, making sure that we kind of recruit a good sample. And Gila keeps saying, George, you got to think the big picture here. The world of healthcare is changing. So we're really appreciating Gila's leadership with that. Our conversation partner today is Timothy Glover. Tim Glover is the Senior Vice President for Mission Integration at Ascension Healthcare. In this role, Tim provides for spiritual, strategic, and collaborative leadership required for the deepening integration of mission, vision, values, and Catholic identity for Ascension throughout all of its sponsored ministries and partnerships. Tim works closely with leadership at the system, ministry, market, and local levels in defining creative ways to express Ascension's Catholic identity within the ever-changing healthcare environment. And that's what we're all about with this morning's webinar, this ever-changing healthcare environment, and collaborating to support Ascension's ministry market executives in their roles as leaders for the ministry of the church. Before Tim became Senior Vice President at the System Office in Ascension in 2013, he served Ascension as Senior Vice President for Mission Integration, Chief Mission and Ministry Officer at St. Thomas Health in Nashville, a place where Transforming Chaplaincy is developing wonderful partnership because they're helping us with our spiritual care and ICU study. Shout out to friends at St. Thomas in Nashville. Thanks for your hard work on that. Before he was at St. Thomas in Nashville, he served as Vice President for Mission Services and Leadership Formation at St. Thomas Rutherford in Murfreesboro, Tennessee. And prior to these executive roles, Tim was a chaplain and then coordinator for the Stress Reduction Program and a consultant in organizational and change management for St. Thomas Hospital. Tim holds an MDiv degree in pastoral psych and family systems from Southern Baptist Seminary in Louisville, and a dual Bachelor of Science degree in religion and psych from Belmont University in Nashville. Tim has been a fellow in the American Association of Pastoral Counselors, now retired, and formerly he coordinated a rural pastoral counseling center in private practice for 12 years. Tim has experience in individual, couple, marital therapy with background and specialization in family systems and post-traumatic stress and anxiety disorders. Tim, we're really delighted to have you today joining in this conversation, sharing your perspectives. Michael, we've already gone past the introductory slide with our lovely pictures. We should pass that one through. There we all are, and you can set your computers to see us as we're speaking if you want. Um, so here's the outline for today, and it's mostly going to be a conversation, and mostly going to be a conversation between Gila and Tim. We want to kind of help people begin to get up to speed about changes that are going on in our healthcare system. Chaplains, I think, probably are quite varied. Some of us may be pretty up to speed on this, and some of us may be just kind of beginning to be aware. So we're going to spend a little time about the changes in the healthcare system, and then we're going to talk about, well, what does that mean for us in spiritual care and chaplaincy education? And then we'll talk a little bit about models and pioneers and next steps and resources, and we'll have time for Q&A. Gila, what if I turn this over to you? Michael, why don't you show us where we are with the next slide? There we go. Gila, do you want to begin the conversation? Are you on mute?
She's advising that she just froze. Yeah, give her 1 second, George.
Thank you. Okay. I know how it feels to freeze sometimes in this technology.
Understood.
You know, maybe actually we can, Tim, I can invite you in.
Sure.
So part of what we often think about as shaping the way we think about changes in healthcare is the triple aim, and Ascension thinks about the quadruple aim. There's Gila. Gila's come back. But Tim, why don't you go ahead?
Well, thanks, George, and thank you for the warm introductions, for the chance to be with this community and really engage in just some shared conversation, strategic conversation, thought partnership together as well. Just kind of thinking about some of these key movements within healthcare that's really, I think, impacting us all. And as we kind of walk through some of the dot points of these, really think of these as an organic, interrelated tapestry, you know, that movement in one of these dynamics really has implications and movements with the other with that. So, you know, thinking about some key changes, at least, you know, a little bit through the lens of Ascension Healthcare, but really inviting in a more general way our shared reflection on the systems that we serve in and through. You may have heard some of this phrase around the triple aim, and some talk about the quadruple aim, meaning that more and more focusing upon high quality at the lowest cost, that also speaks to a very delivery of a certain type of consistent experience from the perspective of those being served. That's the triple aim. And then others add to the quadruple aim, that fourth dimension of the experience of those providing that care. And so how do we deliver and achieve around those four dimensions within healthcare today? And so organizing, designing systems and delivery systems that can achieve that, not only within the acute care setting, but across an entire continuum of care, with particular emphasis around where people live, becomes, I think, a key dimension of that. And Gila, I certainly want to invite you into the conversation and dialogue now that you're with us too, as I've begun to tee that concept off. So let me pause here and invite some of your own thoughts around that, but additional questions as we continue to walk through some of these key dynamics that are creating these change cycles within healthcare.
Yeah, absolutely. And let me just express my apologies. I'm on a system that has some pretty unique security features, so I will hopefully not get disconnected again. You know, just kind of jumping off of the part that I was able to kind of jump back in on, you know, thinking about these different aspects of how people are making decisions within the healthcare system is pretty essential. And so, you know, following what Tim is saying, these are the main priorities of not only administrators in hospitals, but also payers and the government, the federal government, and what they're looking at when they're looking at these different aspects of care. And so aligning ourselves and thinking about, all right, what does it mean to be a part of and paying attention to these major priorities of the major players within healthcare is pretty essential in terms of thinking about future strategic steps within chaplaincy.
Yeah, that's a really important piece to underline, Gila, is that this lens, this hermeneutic, as it were, right, to kind of use our own nomenclature, is really central, as you were saying, not only to those who are the deliverers or providers of healthcare, it's also for the payers. It's also those setting policy and regulations. And more, it's a key lens for non-traditional competitors stepping into this space.
Absolutely.
Wanting to be players in this space.
Yeah.
So I really can't underscore your insight enough. I thought that's tremendous insight that you offer.
Yeah, thinking about what are all these startup healthcare companies doing, they're leaning on the triple or the quadruple aim, and they're entering this new market in a different way, and we already are actually inherently participating in it.
Right. So if you think about Amazon, for instance,
they
forever they've been focused on quality at the lowest cost with the highest experience. So this is space that they're very comfortable in. And they believe they can equally impact this. And so in some ways we're catching up.
Yeah.
And I think, Gila, for me, it touches upon the second interrelated piece. So as we think about the triple or quadruple aim, we began to see this move towards value. Value as understood, especially through the experience of those receiving the services that we have to offer, but also through that lens of quality and, of course, the impact of cost. So we talk about the move from fee for service to value-based care. And that really begins to talk a lot about how providers, be they a physician or nurse practitioner to an institution or to a big practice, it really touches in how are folks compensated for that. So where we used to focus on recruiting physicians because they drive surgeries and admitting to our hospitals, they drive volume. Now it's about how do we really bring the real value in this new marketplace based on how, particularly the government, as you were saying, as the government begins to experiment more and more around compensation and pay based on value. It really begins to change how we think about growth, how we think about our market share. We used to talk about how do we drive volume. We then started talking about how do we drive the right kind of volume. And now healthcare systems are saying, where's the volume gone? It's all moving into these value-based outpatient, which means it's really shifting from a hospital-centric or acute care-centric across the continuum of care. And at least where we see some of the greatest players of new competitors in the space, new growth tactics, partnerships, acquisitions, is around the ambulatory setting and around physician practices, right? It's not as much about how many hospitals can you gobble up. It's really about beginning to move beyond that to the post-acute care setting, because more and more hospitals will be more about cost generators than revenue generators. I don't know if thoughts you have, Gila, or insights.
Yeah. I mean, I just kind of like running back to fee for service in terms of the way that the healthcare system worked pre-ACA, and even as pre some of these other pieces to federal regulation, is hospitals really wanted people in those beds. They wanted people in those beds because every person that came in for every knee replacement, they got money. So each time you had insured a person through, it was cash, right? So when we think about that and this sort of transition to value, part of the surprise for me was It's not so much about pushing the people through anymore. And that move from the high cost of being in a hospital to the lower cost in the outpatient setting, making sure that we have good preventative measures to keep people healthy longer. The major costs in the United States are really centered around chronic disease. Theoretically, we know how to mitigate those types of issues, and which kind of leans into that population health piece of which we'll get to. But I think about when I first heard about it, and maybe many of you as chaplains remember hearing about like the NHS when you and Kelly came to the APC conference some years ago and had talked about how they were moving more and more of their chaplains outside and tying them to PCP offices or primary care physicians, because the work that needed to be done was not necessarily just in the acute setting. It was making sure that they never got there in the first place. And that's a fundamental shift in healthcare, I think.
Mm-hmm. Great insight, Gila. And I think you're right. I think, as you rightly said, it's about, you get folks in that bed and you do as much things to them as you can, and everything you do is a charge, right? And in physician practices, it's the same way, right? It was RVUs, relative value units, right? So everything a physician did was a charge, and that's how they got compensated. And where you see, and as we move to value-based, it's first and foremost about not getting them into the hospital. So we used to talk about readmissions, and then eventually value-based said it's unnecessary admissions, right? So we began to get, to your point, hospitals and health systems began to be responsible for the populations they served, whether they ever stepped into their walls or not. And that began to extend into ambulatory settings, so that physicians more and more, I think you see their compensation models may still have some productivity components to it, like RVUs, but more and more you're going to see compensation tied to their quality, to their clinical outcomes, to the experience of the patients they're serving. And even for some, they'll get compensation based on their leadership, or what many are referring to as corporate citizenship. And so it's a very different compensation future for providers and for institutions, as you say, particularly as we move into population health management.
Yeah, and I appreciate, Tim, that you brought up like a few different factors of leadership, quality, and experience. This is the stuff that the leaders across all sectors of healthcare are talking about. How do we improve quality? How do we improve the experience? Again, the triple aim, and how do we keep the cost down? But also leadership. And I think what we as chaplains sometimes potentially fail to fully recognize or lean into or sort of articulate well is that we do that in partnership with healthcare providers every single day. We are helping to make sure that they're providing high quality of care, because maybe we're helping to define the goals of patients through the lens of whatever their value systems are. We're helping with the patient experience and sort of helping magnify and personalizing that experience in the health system. We're providing leadership and supporting staff. I mean, these are things that we lean into naturally as chaplains, and that we don't often articulate as clearly as perhaps we should.
Gila, I really appreciate you naming that, because I think one of the things we want to maybe tee up for consideration with us here today is that the chaplain is a clinical provider. And one of this transformation in healthcare is requiring all providers to also see themselves as leaders of this transformation. So I want to suggest that spiritual care providers are leaders within this transformation in healthcare, and in particularly thinking about the role of leadership as influencer. And so to me, this is part of the great innovative space, because of the type of holistic interdisciplinary training of today's chaplain. You come with a tremendous integrated skill mix that allows you not only in innovating in the provision and delivery of spiritual care as a key integral component of holistic care, but you also offer the opportunity of organizational influence and leadership, both in terms of equipping other leaders, but also attending to culture, attending to the identity of organizations and how that congruency of that organization's self-understanding comes across in all of its strategic and operational activities and more. So just kind of chasing the rabbit, want to get back on our topic, but I just wanted to underscore that because I thought that was a very powerful statement you made.
Yeah, exactly. You guys have jumped ahead to the next topic about spiritual care. Finish up with population health a little bit here, and the fact that this all didn't begin with the ACA. And the other thing that we talked about is that you've touched on this a little bit, but I think it's worth kind of emphasizing a little bit more. These are very big dynamics that you're describing. What are the ways that chaplains are seeing that dynamic play out locally, if they're just actually only aware of what's happening in the kind of decision-making that's happening at their local situation? Friends, you'll also notice we actually have an updated slide set. So Michael has just kind of put the updated slides in here. Here's a diagram for the triple aim and the quadruple aim. But anyway, back to population health. It doesn't all begin with the ACA.
Yeah, good point. And Gila can certainly invite you in here as my conversation partner with that and your thoughts about it. As I think about it, and again, kind of starting from my kind of lived experience with the health system I'm a part of, but again, inviting you to kind of flesh this in your own experience. I do think it's around a lot of this notion of population health management, and that is you see more and more systems stepping into what we call assuming the risk for the covered lives that they care for within a given community. Again, kind of all the way across that continuum, not only within an acute care context of a hospital, but again, wherever those points of delivery of care can occur. And so, whether that's through certain risk arrangements of per member per fee, of certain capitations where here we're given this kind of lump of money, and out of this money, we're to bring the highest quality at the cheapest cost, greatest outcomes and experience with that piece. And what that means for health systems, and you may notice this too, is you see a lot of mergers and acquisitions occurring. You see a lot of new partnerships that used to be among competitors, but now coming together. Medical schools of medicine and academic institutions with not-for-profit institutions. You see a lot of investment beyond the bricks and mortars of hospitals out to ambulatory settings. For instance, you see a lot of folks looking at orthopedic surgery going to out settings more and more. You see a huge investment into customer-facing technologies that attempt to create transparency, to ease of access, and using AI even in helping customers really access that experience more and more. You see a lot more consumer focus. So your organization may be very focused on its brand strategy today because it's talking about how does it interface with a real consumer mentality. So I think you're seeing systems consolidate, centralize. You see a lot of mergers and acquisitions that are occurring. You see a lot of investment into that narrow network or network capability to keep a continuity of care within its own systems and capabilities, again, so it can manage the data, manage the quality. You see a real investment in data and data being able to interface with one another so that you have that to lead care. You see a consumer focus. And again, as Gila was referring to earlier, you see a lot of non-competitors beginning to kind of come into this space and partner. So you see CVS and Aetna. You see folks like Lowe's in the Cleveland Clinic. You see Humana, Walmart, and Google cooperating. So you see a lot of new spaces. Gila, what's your thoughts around this idea of population health?
Yeah, I love what you said, Tim. I think that the part I would add is thinking from my own experience of approaching this, and when you hear the word population health management, and you hear the word risk profiles, you're like, oh my stars, what does this mean? And what it really gets down to is if you are based in a particular area, how do you touch the lives of all the people in your community or all the people who might walk in, as Tim mentioned? And so when you think about all of the details, it's actually quite simple of a concept, but it is incredibly cumbersome to, the lights just turned off, cumbersome to sort of attach and like work with. So a couple things to think about in terms of like, when I think about population health management and I think about what does this all mean and how do we interface with it and interact with it, people they're not on it. Like this is something that is just beginning in the healthcare space. Like it's been around for a long time. People have been talking about it for a long time, at least 2+ decades of how do we take care of the people in our communities. But the defined way of doing it is not, it's not set yet. And so Tim mentioned a couple great options of like, we're talking about mergers between pharmaceutical companies like CVS and Aetna, a healthcare payer. You're seeing purchases of outpatient ambulatory centers like orthopedics, surgery centers. But what you're also seeing is you're seeing payers and other people entering a different part of the market. And that looks like something that just came out within the last month. Kaiser Permanente is investing in housing. United Healthcare is investing in housing because they realize that housing is an essential part of maintaining and supporting an individual's health. So what do they need to do? They want to enter the stream. That's what population health looks like. It's this full continuum of care and recognizing where you live, what you eat, where you are cared for, what you do every day actually impacts your long-term health outcomes. And if we pay attention to this triple aim of improving the populations, the people, improving health, doing it at the lowest cost possible, and making sure that people are experiencing all of this as best as possible, it means moving further upstream, which is, I think that's the trend healthcare is going to keep moving. The cost piece is probably the part they're trying to figure out.
Mm-hmm. Gina, I think that's a really important piece, and I think this leverages into what's the so what for spiritual care here.
Yeah.
And that is that, depending on who you read, about 20% or less of all kind of interface and engagement of persons we care for relate medically to something medically.
Yeah.
Other 80% plus is around all of this aspects of either socially determinants of health and other aspects from a holistic standpoint, which then I think creates a wonderful opportunity for implications for spiritual care. So I really appreciate that bridge. So
I think I would probably just add this, that, part of what the Affordable Care Act did was sort of cinch up this value-based orientation. And I think we might not fully appreciate it's part of its function was. It was to expand coverage and also improve quality at the highest or the lowest price possible. So highest quality, lowest price was part of the goal, and sort of what has, if you've been in hospitals long enough, you've felt that shift of like, we have to improve patient experience in order to make sure that we meet certain financial, like to hit a certain financial goal, because there are incentives built into the ACA. And so thinking about how that shaped what we do, it just simply said, we're leaning further into the triple aim, and everyone will go to that direction. But I also think the reality is that health systems and payers are going to go that way, whether the ACA existed or not, because the cost of healthcare is exceptionally high, and they have to figure out mechanisms to do it as cheaply as possible, and the best possible way to improve they want to make sure that, like, as Tim said, like branding and keeping those customers. You come back to our hospital every single time. And if you had a bad experience, you're not going to.
Yeah, and Gina, just to underscore too, I think folks ought to keep in mind, a dimension of the ACA was, and I think where it got kind of kicked around based on political counts, but it also at its core was about how do we finance healthcare in this country, right? So, because healthcare in this country for the GDP is about 26%, and there's no sustainability for a country's economics when a particular segment takes that much.
Mm-hmm.
Right? And so it was a lot about financing coupled with value. And to your point, whether it was the government, who is a significant payer of healthcare to this day, as well as other payers, had to begin to get their hands around the economics of this. And part of the kind of phrase out there is that we are all going to have to live off of reduced Medicare rates. So regardless of where you're in, for-profit, not-for-profit, how do you do that? How do you create sustainability of that? And the path out of that is value, is really bringing the highest value in quality that you can.
Yeah.
Friends, maybe it's time to kind of begin the transition from the background about the changes in the healthcare system to, oh my gosh, what does all this mean for us? Begin to pick that up.
I'm trying to do that quickly to have time to invite conversations with folks. So I'll just kind of tell you a little bit of well, go ahead, Sheila. Maybe
I was just say, maybe we want to go back one slide. There we go. Thank you.
Yeah, great. So kind of just thinking about, and here I'll kind of begin drawing upon specifically some of the kind of strategic direction, at least we're anticipating and thinking about from our worldview here a little bit, is that, of course, we see spiritual care also innovating around its models of delivery and what it seeks to impact related to quality and experience of outcomes in that piece. And I think that as we think about, where spiritual care has its greatest opportunity is again, moving also out of the acute care setting. There will always be spiritual care within acute care setting, but beginning to see its impact and its opportunity to influence throughout that continuing moving upstream, a lot of what Gila was talking about. And I do think that spiritual care does bring value add to the model. It can reduce the cost of assuming risk, because key to this work, and I think spiritual care has particular insights into this, is that if health outcomes are in a large part due to health behavior, and health behavior is greatly influenced by motivation, then what impacts motivation? And I think this gets right around the area we're comfortable dealing with, and that is it's around this whole area of beliefs and values, of sense of purpose, of meaning making, how it is we make meaning, our sense of belonging. After all, isolation is identified as one of the top two influencers on health outcomes and compliance and health behaviors. That is, spiritual care has a huge role to offer in helping to activate person's motivation to their health care. And lastly, another piece I think is that I think you're going to see the role of spiritual care, and somewhat historic to its origins, being the role of identifier, convener, or even curator of the spiritual resources and assets of a given community, to bring to bear not only upon an individual, but upon addressing some of the social justice and community barriers and structures to people accessing all that they need to flourish. And so I think you can see that begin to emerge some. Gila, what are your thoughts as you think about this?
Well, I love what you just said, and I wholeheartedly agree that when we think about how the lever, thinking about spirituality or meaning as a lever of influence on health behavior and how that affects health outcomes, like we have to see ourselves in that continuum. And I think we might limit our own vision of where we are in that continuum, and that might be just our failure of imagination to see where we tie to these long-term impacts on health. So I love, like I said, I fully love what you just said, and being able to say, like, we need to acknowledge and lean into the fact that the way that people understand their world impacts the way that they will act. And what we do is inherently about a person's sense of meaning and purpose. And if we can align that with healthcare goals and outcomes, we are aligning ourselves not only with the patient and their needs, but also what our providers and administrators want. And being able to see like those things are not mutually exclusive. They actually work in partnership with each other. Yeah. What do you think?
No, I agree. And I think, as you were saying earlier, looking at comorbid and chronic disease groups are real spaces in which in spiritual care we're used to caring for and have deep insights into. I think when you think about those service lines of ambulatory palliative care, for instance, in advanced care planning, this is a comfortable area for us as spiritual care providers. We have a lot of history here, a lot of insights and knowledge and skill to contribute that, again, following that outside the acute care setting. So I think these all become tremendous opportunities for spirit. And we're often systemic thinkers. We just don't think in terms of individuals. We think of that individual in the context of a matrix and ecosystem of relationships. And so we have that curiosity about ourselves to not only understand what's going on with that individual, but that individual's social network and how do you include that into the treatment plan for that individual. So again, I think we are naturally equipped to move into this space and be a key contributor to interdisciplinary teams, right? That's going to be a huge new model to really cover population health. We have to move beyond the command and control of a physician to really a well-integrated interdisciplinary team of care providers. And I think it gives us a tremendous opportunity to do that.
Yeah, I would agree.
Can you guys address?
George, I think you hit mute.
I did, yeah, thanks, Sheila. So in particular, if chaplains are going to be functioning on teams that are addressing population health, how are we going to measure success, right? How are you going to know that what you're, not yet, Michael, let's stay back there. How are we going to know actually what the chaplain contributed to that? What's going to be, what needs to be on the chaplain manager's dashboard or around indicators of success that they're going to be tracking or that others are going to be tracking to help know what we're contributing and whether or not it's having the effects we want it to have?
Well, I'll give a kind of example where we're beginning to think about that. And I think this ties in to the next slide to follow. So I don't want to jump too ahead to steal our thunder there. But I do think that our ability to really begin to connect the dots of clinically evidence-based practice with outcomes becomes critical. So the whole capability of research and those things all become critical, and measurement become critical for us. And within Ascension Healthcare, we're very interested around the notion in the clinical picture of really kind of spiritual distress. That is, when folks are struggling around meaning and purpose and hope, what are the implications upon quality of life, upon impact of thriving and compliance with treatment plan and care. So we're really beginning to develop, working off of research of others, and George, something you're very close to here, around being able to really recognize spiritual distress and then hone our services to those most critical there, and then recognizing what out of the 10 or 12 things a chaplain can do, what are the 2 or 3 things that really impact this indicator the most, that begins to show up in quality of life, longevity, and other aspects that are there, and measuring that, right? So part of it is not only knowing the indicators of success, but being good advocates for our own discipline to make sure those indicators are incorporated into an integrated dashboard that the whole organization is looking at. So these indicators just can't be something spiritual care is looking at. They're out there for other clinicians and others to see as well, the finance folks and others. But this is something we're beginning to tinker with in chronic heart failure, in veteran care, in first responder care. We're beginning to look at this notion and believe that we in spiritual care have a particular impact upon that indicator.
Yeah, and I'll just piggyback on that, Tim, because I think what a very simple way to think about it, when you know that healthcare is moving, it is data driven, it is data oriented, and we're playing a major game of catch up, and you know, one person like George and a small cadre around him can't lead this alone. We really, I would say we're in a place of all hands on deck in the chaplaincy field. But I would ask you to think about this. What are the major goals of your health system? What are they trying to change? Are they looking at length of stay? Are they looking at readmissions? What are their primary indicators for their success? And then I would think about, what are you doing or what could you do to help participate in reducing that or improving it, and track it and see what happens. You know, we partner with someone who can help you work on the data to be able to present, but align your goals with your health system's goals. And so if you're working on, you know, reducing readmissions by maybe doing follow-up phone calls after discharge on a specific unit, and you see that those people, you see a difference of reduction in readmissions, maybe we might not be able to claim full victory as chaplains, but we can say at least we participated in it, we did it explicitly, and we tracked it. And that can be just even a small success that can move up the food chain within a health system to say, hey, they're participating in this, and we're seeing an effect. And we want to keep this interdisciplinary team together. So I really would strongly suggest that we think about what are the indicators for success, or what are the pain points within your health system, and lean into those.
Yeah, Gila, it's really thinking differently, because we can get caught in thinking in the traditional productivity lens too, right? How many patients did I round on?
Yeah.
Right. How quickly did I respond to a referral within 24 hours of that happening? Those are important process measures. I'm not saying those are not good measures. They are. But how do we move to value? How do we show that because we did X, it contributed to Y?
Yep.
I think your recommendation is spot on. First of all, look at what your organization is already measuring, what it's saying is important to it, and ask yourself, how does spiritual care align with that? How can we begin to think about the work of ministry that begins to impact or contribute to that in some way, and beginning to experiment with what those indicators could be, and beginning to move into that direction more and more.
Yeah.
I think that becomes critical.
Tim, Gila, let's move to the next one and see if we can kind of cover this in 3 or 4 minutes, and then we'll have about 15 minutes for the Q&A. Friends, if you're wanting to kind of join in here with Q&A, use the Q&A box. So move the cursor across your screen. The Q&A box at the bottom will show up. Let's not use the chat for the Q&A function. So as Tim and Gila are kind of commenting on what are the implications of all of this for chaplaincy education, if you all have some Q&A you want to put in there, go ahead, begin to do that. So you think that we can continue to train chaplains the way we have been, or do we need to kind of think that through?
Go ahead, Gila. I know you got some energy around this.
I do. You know, I think that what we do is good. What chaplaincy education provides is meaningful and important, because we are touching really delicate parts of people's lives. But, and we need to start thinking about, how do we fit into the continuum of care? In some ways, we need like a small public health, like didactic that can kind of flow throughout the from the start of residency to an end of residency, to recognize, like, where do you fit in the system of things? You are not a lone ranger as a department or as a person. You are participating in a very large endeavor. I think we need to think about that a little bit differently. And we need to think, how do we move outside of the walls, and how are we training people to do new work? How are we integrating trauma-informed care and looking at, like, acute childhood adverse events? How are we engaging with things that larger systems are paying attention to, that we should be paying? What are we doing with telehealth? Are we engaging in it? Are we training people to not just have the face-to-face conversation, but to be able to do that via video, via webcam, or by telephone? We have to lean into new mechanisms of doing what we do.
I agree, Gila. I think chaplains need to kind of really get up to speed on a consumer-focused approach to ministry. Like any providers, we got to admit that what we do is often serves our needs more than maybe the needs of those we serve, or at least in terms of what's important to them. We refer to that as the jobs to be done. So I think really getting more savvy about really researching and understanding those we're serving, and what do they tell us is their needs? How do they tell us they want to be served? I think you're right. We have to get a lot more comfortable with technology, particularly as we think about more and more of the generations that we're going to be serving. And so how do we get comfortable on using virtual care, on-demand spiritual care, using social media? I think we have to start getting better at using social media, both in terms of our research, but also in terms of reaching out and connecting in those kind of ways. I think you're right too. I think there may be opportunities for additional specialization within spiritual care. So when we think about addiction, when we think about certain populations like veterans and trauma, if we think about geriatric care, often a good place to look is where is your organization seeking to grow its service lines?
Yeah.
And how do you understand the unique needs of patients accessing those service lines, and what could be the role of spiritual care in meeting those needs? I like your idea about being more savvy around public health and social determinant needs of health. I think learning skills around community activation and community organizing could be helpful. Continuing to develop our capacity of strategic thinking as well as influencing skills, I think, becomes important in that way as well, as we, again, I think, learning more and more group dynamics. I think the day of one-on-one spiritual care, how do we complement that with group modalities?
Yeah. Across many channels, not just face-to-face.
Yeah. And even beginning to incorporate some of the disciplines of spiritual direction into spiritual care. And I think the big key here is more and more cultural competency. The issues of diversity and inclusiveness, I think, become key for the chaplain to begin getting more and more skills and equipping others with those same skills.
Yeah. If I were to give major buckets of prioritization, I would think about the substance abuse and, like, the opioid epidemic in the United States. How are we training chaplains to specifically deal with those patient and family member concerns? I would think about chronic illness as a major one. 5% of the population uses about half of the resources, and those people have multiple chronic conditions. If we can make a dent and participate in making a dent, that will be meaningful. And 3, like, in thinking about telehealth, it's not going away. It will continue to grow, and we can be a part of it, or we can be left behind, and we should really be a part of it and advocate. I'll just jump on this last piece around the future of Medicare pass-through in CPE. And Tim, I don't know what your thoughts are. We've talked about this a little bit, but I think that right now, many of you know that CPE gets some funding from first-year residents through Medicare and through the education dollars. I don't think we should anticipate continued funding in those areas. Personally, I think we need to think about how we need to think about our clinical measures and impacts more broadly. And I think hitting some of those areas, telehealth, opioids, chronic illness, and aligning what we're doing strategically with them will probably bring us greater staying power than just a little bit of extra funding.
Sheila, I'll just tag on too, and then that way maybe we can move to Q&A. I think the other area to kind of pay close attention to is you talked about chronic diseases like chronic heart failure, diabetes, for instance, and behavioral health and addiction. Also putting to that lens health disparities, and really thinking through that and the opportunity of chaplaincy within that. I'm like you too. I think it's at risk. I think it's at risk. Do I think the story's written? No. I think our ability to show our value and impact on evidence-based practice, if we can get proactive about that and be responsive versus reactive, I think we could stop that from happening. I mean, again, as we're experimenting within Ascension Health, we're seeing payers come to us to say, we want spiritual care as a component of the lives that we cover. Show us what you do and why that's important. So so it is clearly at risk, and I don't think we ought to assume that it's always going to be there, because we could wake up. We will wake up one day. If we don't do this, we will wake up one day and it won't be there.
Yeah. Yeah. I think that it won't just that it will not go away. It may expand if we can do this well.
Thanks, friends. I think, we had a couple of other slides about models and pioneers. Part of what we want to do there is actually say, actually finding models and pioneers in this field isn't easy. So if people who are participating in today's webinar are out there doing some creative things to address these challenges, send us an email so we know about it, so we can kind of be in conversation. We don't necessarily, I think, see today's webinar as the kind of final answer for all of this. That's clear, right? We're just kind of trying to help chaplains become more aware of these changing dynamics, and then begin to think about how do we work together and work in our own local situations to kind of address some of them. So we are in the Q&A here, and I think Joe Wilson has actually asked a question that might be on other people's minds, and that is, if chaplaincy department has kind of a limited number of resources, limited number of FTEs, as we think about addressing some of the things that Jill, you and Tim have talked about, do we shift some of those FTEs from acute care to outpatient care to begin to kind of provide upstream care, to demonstrate the value of spiritual care at the upstream level? If you have to make trade-offs, how do you do that?
Yeah, I mean, I think there's strategic risk in moving people, but there could be incredible benefits as well. I would say that if you can move one person, start with one person a half a day to work on outpatient work. And if you have a complex care team that's in your hospital, that might be a good place to lean into. And put them there and see what happens. Say, can we screen your people for distress? And if they have it, can I meet with them when they come in for clinic visits, or talk to them by phone? If you want to start small, but start somewhere. And recognize that there will be things that there may be new gaps in the acute setting. But as long as they are calculated risk gaps, it might pay off in the long run, because you might actually increase your FTEs.
Mm-hmm. Yeah, I think that's good insight, Sheila. I mean, that's our approach has been to make some pretty bold organizational moves in the direction we think is critical strategically. And that tension that you're drawing upon the same capabilities. So what you're kind of doing today, what you're trying to do tomorrow, you're drawing upon that similar resource, but again, beginning from a kind of change management. So for us, if we're saying that we believe that spiritual distress is really critical, it helps us to really know where we need to be most critically. Then beginning to do that in any setting makes sense, right? And developing that capability. And then again, if we're talking about doing that from a continuity of care standpoint, then learning to do that when it's with this patient in the acute care setting, how do we follow that patient then beyond the acute care setting, even if that means a transition of care. So I'm seeing this person in the ICU, but as they transition out, they're going to be handed off to our on-demand spiritual care team who are going to follow them virtually.
Yeah.
perhaps, you know,
Yeah.
and back and forth. And I think for us, part of the mental model change for us has been too. So some of this work is internal to chaplaincy, right? So I'm used to my parish being these 4 brick walls of Hospital X. What we're beginning to experiment with is that if I'm an Ascension chaplain, I'm an Ascension of this geographical landscape, right? I'm not limited to any particular delivery site. And so how do you begin to think about that from an identity standpoint?
And so Jennifer Jarvis is actually kind of picking up on this, and she said, you know, the FTEs are funded by the acute care. They're kind of in the budget in the acute care. To shift an FTE to the outpatient, right? How do you shift that budget? How do you make that happen?
Well, you can talk to your hospital leadership and have a conversation and say, hey, we see that reducing readmissions is important to you. I would like to send one of my acute care chaplains, people who are assigned to this unit that is mostly aligned with where you want to reduce readmissions. I'd like to spend half a day, start with a half a day, and see if we can have them work like making discharge follow-up phone calls and checking in 2 weeks after or 3 weeks after, for example. Start anywhere. Be transparent and be open. All of us know the pressures of, many of us know, I mean, having been a chaplain and a manager in a health system, there are only so many hours in the day, which is true, but you also have to make some strategic priorities, and it's hard and it will be uncomfortable. But I think that having a conversation about what is important to your health system and making sure what you're doing ties into that will make a bigger impact, because you might find that you will get increased hours for FTEs when they see that you are making an impact on their readmission rates, for example. I think that we are maybe as a profession less risk averse than many others, but sometimes you do have to take a little bit of a chance to see what happens.
I think a couple of things. I think one is it speaks to new competencies we need, and that is we have to learn how to develop business plans to support the kind of operational changes we're wanting to make, and how to really do that and articulate that with the stakeholders, decision makers, right? To do that. So to your point, Judy, if we're looking to move to outpatient, what's the business plan on that? What's the value add of us doing that? And being able to really put that and articulate that becomes critical. So we got to learn to think that way a little bit, right? The second thing is to say, leverage probably where your organization is already moving. Part of this big movement of health systems is moving from being holding companies to operating companies, which means that those budgets begin to get more and more consolidated. So whose dollars belong to the hospitals versus who belongs to the ambulatory, whose budgets they sit on, all of that stuff is getting to get mixed in there together, right? And you can leverage that opportunity to do that. Two approaches we're doing in Ascension Healthcare ourselves is that based on our operating structure and therefore the organizational structure, is where the employment of our chaplains sit at a ministry market level, not at a facility level. And so they sit on the system's budget so that they can be deployed. Second of all, we've developed, in the process of at our alpha level, developing a chaplain productivity tool that's based on population health, not based upon, for instance, adjusted discharges, right? And so how we begin thinking about, and health systems are doing this too, to Gila's point, we're beginning to change our measures of success. And so how do you use those same measures to inform what does productivity look like? So those are two ways that we're trying to leverage within our organizational construct to do that very thing.
Thank you, Tim. Thank you, Gila. We're going to move toward wrapping up here. There are some additional questions. A number of people have kind of said, do you have good examples about how you would measure the reduced readmission rates for doing this? Do you have good examples of the business plan that Tim is talking about? I would say, as somebody who kind of reads the chaplain literature, who goes to webinars and things like that, we don't have a lot of good examples. Part of what we're trying to do today is kind of raise the question, ask people, you know, what are you doing? Who's working in these areas? Who has examples? If you are working in these areas, you've got examples of a business plan, you've got examples of kind of shifting chaplaincy care to wellness care, and you're beginning to measure that. Raise your hand, let us know about that. Send us contact us through Transforming Chaplaincy so that we can learn about that. We can begin to share the news. So, Michael, if we move ahead on the slides here and we get to the, so we'll do this again next year. Our kind of strategic thinking webinars, we do 3 of them a year. We kind of begin in the winter, so look for information on Transforming Chaplaincy about how we kind of continue this conversation, develop opportunities to kind of bring out more information that kind of follow up the conversation we've begun here. And I think the next slide actually talks about a, so one of the things that we want people to know is actually one of the next new things that Transforming Chaplaincy will be doing will be developing a certificate in spiritual care management and leadership. We're developing it here at Rush in partnership between Transforming Chaplaincy and Rush's Department of Health Systems Management, which is ranked in the top 5 health systems management departments in the United States. We'll probably begin a year from September 2019. If you email Michael Skaggs, you'll see Michael's email address here, and he's our Transforming Chaplaincy Communication Director. We'll be continuing to kind of roll out information about the details of the certificate. So when Tim says, you know, we need to learn how to develop business plans, well, most chaplains haven't learned how to do that. So we hope that the management certificate will be a place where people can begin to kind of have those experiences. Tim and Jill are going to give you a minute each for final thoughts, and then we'll be wrapping it up.
I would just, first of all, again, my deep gratitude and thanks to everyone, to you, George, Gila, especially as a thought partner and conversation partner, and just your great insights of this stuff. I just want to kind of leave a word of encouragement to say this is something we should not be afraid of, but incredibly excited about. This is like ingrained into us as spiritual care providers. This type of innovation, creativity, you know, always designing to need and to meet need. If anybody can do this type of innovation and transformation, it's this vocation, this profession. And so I think really the best days of spiritual care are in front of us, the best days. And so I really, really want to thank you for what you do every day, and to invite you to really continue to be prophetic, bold, and always choose adventure over safety.
Thank you, Tim. Gila?
Yeah, I thank you, Tim and George, and for letting me be a part of this and then be a part of the conversation. It's something that frankly, when I was working as a staff chaplain and in this work, I didn't fully appreciate how complex the health system was. So I know that it feels daunting at times, but like Tim said, we actually do this all the time, and we're pretty dang good at it. All it is sort of realigning our language, recognizing that healthcare is shifting to this value-based model, and the essentials of who we are and what we do is all about value, and value and values, I would say, and just leaning into that. And Tim said it well, you know, be bold and be brave, and choose the courageous path. It will be hard, but I think that if we start making some of these harder decisions and move into harder places, there's some good. And there are large conversations happening. As Tim said, there are payers that are interested in how spiritual support can help impact the patient experience and the member experience, and they care about this too. We just need to sort of step up to the plate, and I hope we can.
Great. Thanks, Gila. Thanks, Tim. Friends, as you see on the screen here, this session was recorded. The recording will be posted both at the ACPE Academy and the Transforming Chaplaincy. So if you want to share it with friends and colleagues, you can do that. Again, the beginning of a conversation, we hope to continue it. If you're involved in some important innovation in these areas, please let us know. We'll be back next year as we continue this, and as we kind of wrap up. Thanks to the guys in the background. Carl, thanks to you. Michael, thanks to you for your tech support here and helping us do this well. Have a good summer, friends. We'll be back in touch next year.
All right. Thanks. Thanks, everyone.
We may be, are we in a post call here? We may not be. We may still be public. Sheila, you were on mute, but I think we'll wrap it up here. And just want to say thanks to you. Thanks to Carl. Appreciate your help. Everybody, I think it was an important start to a conversation.
Yeah.
And we'll be in touch.
Yeah, that sounds good. Sorry about my, I was attached to the Wi-Fi here and the security was like, no, not so much. But
yeah, a small hiccup. It was a small hiccup, Sheila.
A small hiccup, but we fixed it.
We did. Good.
Thanks, George. Have a great rest of your day.
You too.
All righty, guys.
Bye-bye.